Welcome to our channel. Today, we're diving into a fascinating and life-saving topic, perioperative myocardial infarction, or MI, after non-cardiac surgery. We'll analyze a real-life case of a 75-year-old patient whose condition took an unexpected turn after surgery. Stick around for key insights backed by groundbreaking research like the POISE and VISION studies. Meet our patient, a 75-year-old woman admitted with gastrointestinal bleeding caused by a perforated duodenal ulcer. She had GERD, glaucoma, osteoarthritis, and untreated dyslipidemia, but no history of heart disease or smoking. She underwent emergency laparoscopic surgery, and her preoperative troponin levels were normal. For 5 days post-surgery, she recovered smoothly. No chest pain, stable vitals, ambulating well on post-op analgesics, and preparing for discharge. Then, on post-op day 5, things took a dramatic turn. She suddenly developed atrial fibrillation, with hypotension with a BP of 76/60, and oxygen saturation remained greater than 96% on room air. She received a bolus of Ringer lactate 500 cc, her BP was noted to improve to 117/80, and her heart rate remained at 110 BPM. She was started on metoprolol for rate control. After receiving IV fluids and amiodarone, her blood pressure improved, and she reverted to normal sinus rhythm, but her troponin levels spiked from 61 to over 3,000. Still in normal sinus rhythm with no acute changes. She was initiated on aspirin, statin, and metoprolol. CTPE done was negative for pulmonary embolism. Interestingly, she was asymptomatic with no chest pain and no overt signs of ischemia, possibly with a role of post-op analgesics on board. Faced with rising troponin levels and no symptoms, what would you do next? A. Request for immediate cardiac catheterization and transfer to HIU, or B. Discharge on optimal cardiac medications with cardiology follow-up, or C. Request echo, if normal, optimize cardiac meds, refer for outpatient cardiac CT and post-op clinic. Pause the video to think of your answer. The team chose to optimize her cardiac medications. Perform an echo. Echo done showed normal LV size, normal wall thickness, normal wall motion. The ejection fraction was 60.2%, an outpatient cardiac CT and follow-up were scheduled, and the patient discharged home. The cardiac percentine study revealed severe multivessel disease, including complete blockages in the LAD and RCA arteries. The patient proceeded to cardiac catheterization, which confirmed 2-vessel coronary artery disease with LAD and RCA involvement. Proximal RCA 100% stenosis, mid-LAD 100% stenosis. We recommended coronary bypass graft versus medical therapy. PCI was not ideal here in our patient's case, given the asymptomatic status, 2 complete total occlusions in RCA and LAD, and a history of GI bleeding. The patient opted to accept the risk and continue medical therapy as she was asymptomatic. Now, let's break down what research tells us about cases like this. The POISE trial by Dr. P.J. Devereaux and team at McMaster University in Hamilton, Canada, revealed that 85% of patients with perioperative MI had no ischemic symptoms, and 75% of MIs occurred within 48 hours post-surgery. Importantly, aspirin and statins reduced 30-day mortality rates by 46% and 74% respectively. The VISION study added that preoperative statin use significantly lowered the risk of all-cause mortality, myocardial injury after non-cardiac surgery, and stroke within 30 days. These findings emphasize the role of proactive perioperative care in preventing complications. This case is a powerful reminder of how silent yet dangerous myocardial injury after non-cardiac surgery can be. Routine troponin monitoring, statin use, and individualized treatment plans are critical in high-risk perioperative patients. If you found this discussion insightful, hit that like button, subscribe for more case-based learning, and share your thoughts in the comments.